Well, good evening. Hello. There we go. I see some faces. Great. Well, it's 7:02, so I think we'll just go ahead and jump in and get started this evening. I want to say welcome to the Local Health Improvement Coalition Community Health Planning Meeting. My name is Dorothy Fox, and I am the Executive Director of the Partnership for the Healthier Carroll County. And I'm really glad that you've been able to join us tonight. I'd like to first send out a big thank you to
Recording
Richard Turner,
in progress.
Bob Blueball, and the team at the Community Media Center for hosting this meeting. And I'd like to give a special recognition to Maggie Kuntz for all of her hard work in bringing this meeting to fruition. I really appreciate everything you've done, Maggie. Thank you so much. If we want to go ahead and go to the next slide, because I think we have some directions on that next slide, Maggie. Great, thank you. So while I make introductions to the presenters tonight, if you want to go ahead and fill in your name and some of this information in the chat feature, you can introduce yourselves to each other while I introduce the team here tonight. So we do have a jam-packed schedule, and I'm going to introduce the speakers in the order that they present. So speakers, if you wouldn't mind maybe waving as I introduce you, that would be great. First up will be Sue Doyle, the Acting Health Officer. We have Amy Baker, Director of Special Populations. We have Ann Grau from the Cigarette Restitution Fund. We have Maggie Kuntz, the Health Planner. Lauren Harrison, the Health Educator. Dr. Robert Wack, the Deputy Health Officer. And Tasha Kramer, the Director of Community Health for the Partnership. So I believe at this point, I am turning it over to Sue. Sue, good evening. Are you with us?
I am here.
Great. Hi, Sue.
Thank you. Welcome to everybody. I'm Sue Doyle. I'm the Acting Health Officer for Carroll County right now. And I think on the next slide, Maggie, I'm going to go over the agenda. And for those of you who know me or have ever been in a meeting with me, you'll understand the humor in this. This is my hardest thing to follow. I get started talking and I get off topic. So I think they gave it to me for that purpose. So the goals for this meeting are to be, we're going to share what the community health planning looks like in Carroll County right now. We're going to discuss some of the priority areas, and we're going to develop some next steps for community engagement in the local health planning process. We're going to review our community health planning orientation and our community health needs assessment overview. We're going to have an update on cancer screening and tobacco programs. We're going to do a diabetes action plan and what initiatives are included in that. And we'll do a little COVID-19 update and next steps and opportunities for involvement. I believe we're back to you, Dot.
Okay, great. So the next slide, we're going to talk a little bit about population health. And oops, I see we have another slide in there.
Sorry, that's the one I snuck in. Just to remind everybody to please mute yourself if you're, unless you're speaking. Please be respectful of others. If you have questions, Lauren and I are going to try to monitor the chat. But I have a lot of things going on my screen. So, if we're not able to get to you, we will we'll try to get to you at the end. If you have more general questions or brief information to share, we'll try to get to that at the end of the presentation. And I just wanted to say we are thrilled to have some private business partners here on the call today, but we just ask you that you please refrain from promotional announcements, that we're all here just to learn today, and hopefully we'll have opportunities to network in the future. So, all right, sorry about that, Dot. Thank you.
No problem. There we go. Population health is a term that is often used to describe in health planning and health care. As this diagram kind of shows, that population health is the overlap between the clinical services and public health. It's become very clear over the past, especially the past several years, that it's really necessary for community partners to work together to effectively impact change on everything ranging from social determinants to acute care. We need to develop policies and interventions, all with the goal of improving the health of our communities that we serve. How we do this in Carroll County is actually represented in the next slide.
Okay, I'm going to give a little bit of a background on the Local Health Improvement Coalition in Maryland. So the coalitions are at the local level members that help to inform and address local public health priorities. This was originally created in 2011 and with the state health improvement process, which was aimed at improving population health outcomes and measuring jurisdictions on their performance in 39 different population health metrics. Local health improvement coalitions were tasked with addressing these state health improvement priorities. Members can come from any part of the community or organization. They can contribute to population health efforts by pooling their skills, insights, and/or resources, and shared leadership between community representatives and the anchor institutions like the health department and the hospitals. Maggie is next.
Myself, too many buttons. So in Carroll County, the partnership board served as the LHIC for some time, while their access to health leadership team served as the local health improvement team. So it got pretty confusing because there were a lot of LHIC things. But now these two groups meet together, and we meet quarterly on Wednesday mornings, the third Wednesday of the month, and get together and talk about a lot of these issues that we'll talk about. So this group the great thing about this group is that we work on a lot of multidisciplinary issues, things that aren't easy for one agency to tackle at a time. So it really is a great way for community partners to address issues that affect people across the board that just really take some multidisciplinary solutions. So this group was already working on some of those things, and the LHIC really added some additional public health issues and data. So it was a great fit. The partnership also has other leadership teams working on community health and wellness that we'll talk about later. So I just want to make sure that you know that those things are going on as well. In 2017, the local cancer coalition joined because it was a natural fit as well to include some of those pieces that the partnership covers in their needs assessment, and that plays a big role in some of our other teams. So they joined us as well. So you'll hear from them. And then just recently, this new funding and direction from the Maryland Community Health Resource Commission was added in 2020 during COVID. So that's why we've extended things a little bit, but this is part of that grant, which really focused on increasing community engagement. And so this is our, goal to go about increasing community engagement and partners between the needs assessments, which do a great job of, reaching out to diverse community groups. But we wanted to try to do that between the needs assessments, so there's more opportunity for involvement. So we're really focused on increasing community engagement. And then I think this is still me. Just wanted to let you know, these are some of the agencies that participate in the LHIC, the LHIC and Access to Health team that meets together quarterly. So you can see there's quite a diversity of agencies that participate. And many members are here tonight. Lou from Catastrophic Health Planners is definitely one of our stalwart members, and lots of other folks who are here tonight. So we really have a diverse group of people who get together to talk about these health issues and, like I said, like multidisciplinary solutions to them. So just wanted to let you know who we have involved, and we're hoping to get more folks involved as well. All right, back to you, Sue.
I'm going to review the mission and the goals and the objectives. So the Local Health Improvement Coalition redesign grant is to refresh the mission, goals, and objectives, refreshing those things as a part of this redesign process. The mission and the vision of these three organizations are the foundation of the LHIC and the population health focus. So we have the Partnership for Healthier Carroll County, who strives to build capacity of individuals and organizations to improve the health and the quality of life in Carroll County. Their vision is to achieve the highest level of health possible. We have the Carroll County Health Department that's dedicated to promoting health, community health and wellness by educating and protecting the public through collaboration with community partners. And our vision is a safe and healthy community for all. And then the Carroll Hospital Center's mission and vision summary is an uncompromising commitment to the highest quality of healthcare experience for people in all stages of life. We take responsibility for improving the health of our populations through our care management and delivering high quality, low cost services in the most appropriate setting.
I'd suggest that you take a look a little bit and then hit it.
I think Dot's next.
You're muted.
Thank you. I'm so sorry. So the community health needs assessment is a requirement of every hospital in the country to be completed every 3 years. And this is part of the Affordable Care Act of 2010. In Carroll, we go well above and beyond to make sure that we really gather the information that is most valuable to our community. Our assessment really includes 3 main survey collection pieces: the online community survey, which asks people about their health and the health of their families. We have focus groups that represent specific high-risk groups. And these groups we actually continue to expand on each year. And we hope that that is a pattern that we can proudly continue into the future. We had 10 focus groups this year. And we asked these focus groups questions. Each session is moderated. And we ask them to represent their community. And then the key informants, we call together leaders in the community and we ask the same questions. We ask the focus groups, but we ask them to also speak on behalf of the clients that they serve. On top of that, we use all of that information. We also collect secondary data. And when we compile all that information, we actually do a prioritization process, which I think is the next slide. So we do a prioritization process, and this prioritization process, we bring together a lot of people from the community, really the health leaders in the community, both from the hospital and from the health department. And we present all the information and we say, tell us what is the most pressing issue that we're going to work on. And this is how it actually came out this year. We prioritized 13 areas, and the top 4 were mental health, diabetes, cancer, heart health. And we actually are using obesity in the areas because, as you know, they are all interrelated. You affect one, you can affect the others. So I want to also point out, this doesn't mean that we won't work on any of the other areas. It just means that these top 4 areas that are prioritized will actually have a plan in place with responsible parties identified, as well as accountability to make sure that we are moving these indicators, saying we are making some change in our communities. So Tasha, I would like to ask you now if you can share how these areas are addressed in our leadership teams and our action teams, especially as it relates to diabetes.
Absolutely. So each one of these, what we do is we take the top 4 and we created goals within our leadership teams. And I'll explain our leadership teams a little bit later, but we've create goals and then these initiatives to complete throughout the next 3 years until the next community health needs assessment is done. And that's done by our action teams. So we have leadership teams, and then on that leadership team, we have action teams. And those are the people who actually are on the boots on the ground, doing the work, doing the activities and things. So we have a nutrition action team, and that is where the diabetes falls under. And we're working with the health department in the hospital and nutritionists, dietitians, and to work on addressing diabetes and what that looks like as far as improving classes for the DPP program or diabetes education or incentives for the Living Well series that's done through Citizen Services. So really encouraging people to take these classes and educate about diabetes and pre-diabetes as well. Is that good?
Thank you, Tasha.
Okay, we're back to the local health improvement plan process. The local health improvement plan incorporates findings from the community health needs assessments, as well as public health data. The Local Health Improvement Coalition reviews that data and information, looks at what services are available in our community. We look at the gaps and the barriers to those services, and then we develop action steps. Our current priorities include access and awareness to services, lead screening guidelines, average lead levels in Carroll County, resources that are available to assist people with those efforts, impact on public school program to take children to the dentist, ways to increase flu shots in the younger adults. There are many initiatives for children and older adults, and then affordable housing. Under the next heading of behavioral health, we're looking at the suicide rate in Carroll County, And we're looking at drug-induced mortality rate in Carroll County, as well as adolescents who use tobacco products and electric nicotine delivery systems. The last area that we're looking at is chronic disease, and that's cancer screening and prevention focused on skin, breast, and colon cancer. The new local health improvement plan will be finalized this spring, despite our limited access to updated data at this time. We're going to move forward with what we know and what everybody feels that we should be working on. Okay, the local health improvement plan process and priorities. Noted are the priorities that appear in the community health needs assessment and the community benefit and health improvement plan for Carroll Hospital. So access and awareness to services and priorities. As I said before, the blood lead screening in children and adolescents who have received wellness checkups, children who receive dental care, emergency department visits for dental care, annual flu vaccinations, affordable housing, which is a social determinant of health. The behavioral health priorities include the suicide rate, the drug-induced mortality rates, adults who smoke, and adolescents who currently use tobacco. Under the chronic disease priorities, we have heart disease mortality rate, cancer mortality rate, emergency department visits for diabetes, adults who are not overweight, obese, and increased physical activity. Older adult priorities include hospitalization for Alzheimer's or other dementias, fall-related death rate, and other health priorities include chlamydia and life expectancy.
Okay, I'm up next, and before I move on to the next slide, I just wanted to let you know I did make these slides, and I realized as I was watching that I think it wasn't completely clear on this slide before. Some of the issues that we were listing here were issues that we had looked at more closely as a group, the LHIP and excuse me, the LHIC and the access team, because we agreed there were things that we felt like what the data showed Carroll had some concerns, and we felt like we wanted more information. So the group actually spent a couple of years looking at these priorities and trying to learn more about these issues. So that was kind of part of the buildup to our LHIP. It's just been a long time coming now to write the plan, because as Sue said, between the fact that we've been busy with COVID and of course, our data has been somewhat held up and delayed. We haven't been able to complete that, but we are working on it. And these priorities are really all the priorities that we'll cover in the plan. And you can see how much they overlap with the CHNA, the needs assessment, and the hospital's plan. So a lot of room for overlap, but just a few additional public health priorities. So sorry, that wasn't super clear on those two slides. So I did ask everybody to do a couple of polls just to kind of find out how your interests aligned with some of the things that we have in our plans. And as you can see, about 26 people, a couple people managed to scoot in at the end that I didn't catch, I'm sorry, but the priorities remained fairly similar. So looks like mental health is way at the top there. So that's something that, we're definitely, all of us are working on and aware of, and it's part of all the plans that we are moving forward. So we'll talk a little bit more about that, but definitely that's a priority here. Diabetes is also a big priority, and you'll see it's actually part of this redesign grant. There's a small part that's diabetes focused that we'll be talking about in a few minutes. And then access to healthcare, that's the name of the other name of the team that we put together is Access to Health. And so that's definitely something that we want to hear more about, what your thoughts are there. And then several of the other things you can see that are sort of moderate priorities here are definitely things that are on one of the lists that we just talked about. So, so definitely a room for a lot of those issues to be a part of what these groups are doing and to be expanded, kind of upon by your experience in the community. And then the second poll question, a few less responses or few less options. What do you think the three biggest barriers are to good health? Because as Sue mentioned, in addition to, of course, reporting on the data, what the data shows, we also are taking a look at what barriers there are to, accessing the resources that are available in the community. So I thought this was an interesting result. Cost of care was very high. Lack of transportation, that's not a surprise. That's something that's certainly actively being worked on. But lack of knowledge was the top answer. So I thought that was interesting. definitely something I think we could all contribute to, right? Increasing the knowledge about the resources, the health issues in our community and the resources to address them. And then health equity and discrimination, also a pretty important barrier there. So good to have those issues brought out. This is a really interesting poll, so I appreciate everybody taking the time to answer those questions. Right, and I know we're flipping around, but back to Dot.
Okay, so the polls, especially with the graphics, I love the graphics, are of interest to me, but it goes beyond that, because I think it's really important to understand that this is data that we collect, and we use all the data that we collect, whether it's now or in the future. So again, I would like to also reiterate that I appreciate those who have taken the poll. So through the LHIP, the data is also very important. We have inclusion of data from the SHIP, the state and national sources. And these are discussions that we have with the coalition. So we're very proud to say that our decisions are data driven. The coalition members are really active throughout the entire process with the gathering, the analysis, and the interpretation of this data. The data is presented, followed with questions and discussion, which then actually lead to the community actions. Some of the reliable data sources that we use are the SHIP, the State Health Improvement Process data, the health department's annual reports, and then the community data dashboard that is hosted on the partnership's website. We found that this has been very helpful for many of our community organizations for grant applications, reporting, and some numerous other reasons for being able to pull that data. I think we're on the next slide.
All right, now we're going to hear a little bit from Amy Baker, who runs one of our sort of subcommittees of the local health improvement team, access team.
So good evening, everybody. Thank you, Maggie. I work for the Health Department's Behavioral Health Bureau. And so one of the things that our Bureau is tasked with is looking at health equity and how we can make our services in the public behavioral health system more equitable. So as part of the LHIC, we look at the access to care. We're really looking at data and using the community health needs assessment through the partnership and local health planning and initiatives. But we also have a local class, what is called CLASS. I like to call it Keeping It Classy, which is an acronym for Cultural and Linguistic Appropriate Services. And so I am fortunate enough to co-facilitate that group with Tasha Kramer on a monthly basis. And it is a work group that we formed about a little over a year ago. If you look at the graphic, which is really excellent, we look at what's equality versus equity. And equality really is we all get the same thing, regardless of our abilities or capabilities. And equity is we all get the appropriate thing so that we get the things we need and the tools we need to live our daily lives and raise our overall quality of life. So it is a great graphic. We hope to expand our health equity focus by increasing community engagement with diverse partners, and I'll tell you in a moment how we're working on that. And as the graphic suggests, those health inequities are reflected in the differences in the length of life, quality of life, rates of disease, disability and death, severity of disease, and access to treatment. So when we look at the social determinants of health, Sue had mentioned, inappropriate housing or poverty or food scarcity. Those are all things that we're looking at in relation to health inequities. Next slide, please. So what is culturally and linguistically appropriate services? Basically, it's a set of standards to help organizations meet the needs of their clients in a culturally and linguistically appropriate manner. So what does that mean? It really means that we are looking at the needs of the client, the whole person, in order to best respond to that person and again, increase their overall quality of life. So we're looking at a person's language needs, and that if English is not their first language or they don't speak English, we're either getting them somebody who speaks the language that they speak in the behavioral health realm, or we are making sure that there's interpretation available. And that includes for clients who are deaf or hard of hearing. We take into consideration their cultural backgrounds, their religious, their spiritual backgrounds, as well as their gender identification and their sexual preferences, to really wrap around and provide a welcoming environment for that client when they're entering into our community behavioral health services. It's really a way to, class is really a way to respond to the needs of the community and to right those wrong inequities. And basically, as you see, examples of class are communicating in the preferred language of the person, acknowledging culture as part of the person, validating and embracing diversity of staff and clients. So we address workforce, leadership, and governance. We're looking at multimedia representation, and that is for like what is in our waiting areas, as well as what's on our social media and our websites. And as I mentioned, inclusion of religious and spiritual beliefs. The practical ways that we're doing this is we're developing a strategic plan in tandem with a consultant, Dr. Karen Francis, and we're developing a community survey to really address, are people getting what they need when they access services, or are they not accessing services because the things they need are not available in relation to equity and inequity. Researching data on inequities in the county, developing a contact list of significant advocates for the more vulnerable or less served populations, conducting walkthroughs of the agencies to really see where we are lacking in these class standards, reviewing policies and procedures with a class lens, and welcoming community members to the table within our work group. We meet the third Thursday of every month from 9 to 11, and we definitely welcome participation on that work group. Thank you.
I'm going to try to pull this all together. The statewide integrated health improvement strategy. In December of 2019, the Maryland Centers for Medicare and Medicaid Services signed a memorandum of understanding agreeing to establish a statewide integrated health improvement strategy. This should really be fairly simple for the state of Maryland to do, because we've already been working on the state health improvement process, as well as at a local level, we've been working on our local health improvement plans. This initiative is designed to engage state agencies and private sector partners to collaborate and invest in improving health and addressing disparities, reducing costs to all Marylanders. And the state submitted its proposal outlining the goals, measures, milestones, and targets to CMS, well, actually the Center for Medicare and Medicaid Innovation, on December 14th of 2020. Maggie's put a link here to where the full proposal can be viewed. And then the guiding principles for the statewide integrated health improvement strategy is that Maryland's strategy should fully maximize the population health improvement opportunities made possible by the total cost of care model. Goals, measures, and targets should be specific to Maryland and established through collaborative public process. Goals, measures, and targets should reflect all payer perspective. Goals, measures, and targets should capture statewide improvements, including improved health equity, which we just heard about. Goals in the 3 domains of the integrated strategy should be synergistic and mutually reinforcing. Measures should be focused on outcomes whenever possible. Milestones, including process measures, may be used to signal progress towards our targets. And Maryland's strategy must promote public and private partnerships with shared resources and infrastructure.
So I don't know if Sue got a chance to mention, but some of the part of the grant is it asked us to have some community health trainings, basically. So this was a way to incorporate. So that last couple of pieces were pieces that we were asked to include. So it just kind of gives you this perspective of how what we do aligns with what's going on at the state and federal levels. With a lot of fancy words, but that's basically what we're trying to communicate. So now we're gonna hit a couple of very specific areas to just let you know a little bit more about what's going on in those areas, some of the areas that we're really focused on. So we asked Ann Grau, who's one of our cancer program specialist to give you a little overview of some of our cancer screening programs, just to raise your awareness of those, because they are, part of what we're doing in the Access and LHIT team.
Thank you. So I'll start with the breast and
You're muted, Anne.
Sorry. Not sure what happened.
all right. We'll see if I can stay on this time.
There we go.
Okay. It keeps saying the host muted me. All right, we'll try again. Sorry about that. The breast and cervical cancer program does provide these services that you can read there. And the eligibility for that is women ages 40 to 64. These are people that qualify in terms of their annual family income, and they are either uninsured or underinsured. So they may have a very high deductible, for example, or a high copay. We use a provider in Westminster, and we also use advanced radiology to do the mammogram. If there are any abnormal results, then we have programs that can cover diagnostic testing, surgical evaluation, surgery, etc. And you can see the phone number there for that one. Colorectal cancer screening is also another program that we do. Our program provides for an office visit. We use 2 providers in Westminster, and they can go to either one of their choice. We cover the colonoscopy, we cover the preparation for the colonoscopy, and any additional testing if that's needed, such as diagnostics in the lab. This is for ages 45 and over for routine screening. However, if a person is younger and they have either problems or they have a family history that is very significant, we will see them at a much younger age than 45. Again, this is for a Carroll County resident. They have to qualify in terms of income, and they are either uninsured or underinsured. And if there are any abnormal results that show up there, there are other programs that could help them if they need cancer treatment, for example. For both of these programs, there is no cost to the patient for the services. We can also help people that are income eligible if they do have insurance but need navigation. And quite a few of our clients just need a lot of help to access the services that they need, and also some coaching to get there. We have seen a significant increase in Spanish-speaking clients, and we are able to help them because they, first of all, may not know where to get services, but also we navigate and we can communicate with the office and then with our interpreter to talk to them and get them there. And finally, the tobacco use prevention and cessation. We do education and public outreach. Not so much during COVID, but we have been getting back into that recently. Maggie has done some social media messages for us throughout COVID, and we continue to do that. The smoking cessation program, and by the way, I should mention that all counties have this service, as well as breast and cervical cancer, as well as the colon cancer screening. So if we get somebody from the wrong county, we can refer them to the county that they live in. For smoking cessation, we will also see someone who works in Carroll County, for example, even if they don't live here, or if they receive their other services in Carroll County, we'll see them. Excuse me, there is no income or insurance requirement for smoking cessation. We'll see anybody, and we will help as long as they are continuing to make progress. We will do counseling. We found during COVID that it's very effective to do that on the phone. So we have been doing much more of that via phone. We also will help them to access apps if they prefer that, or if they prefer texting support, we can help them to get that. And we will provide nicotine replacement in terms of patches, gum, or lozenges. And really, behavior change along with that nicotine replacement therapy is the most effective treatment. And that's what we try to stress. But if somebody doesn't want nicotine replacement therapy, we will help them with counseling alone. So that pretty much summarizes it. If you have questions, please feel free to call any of those numbers. We'll be glad to answer them.
Thanks, Anne. That was a great overview. So now I asked Lauren Harrison, who works with me on this, on the LHIC redesign grant, to kind of cover the diabetes initiative, which we are partnering with the Nutrition Action Team to accomplish.
Hi, everyone. I'm Lauren Harrison. I am a health educator at the health department. So I help run the diabetes prevention program that we run there. We do have a couple of other diabetes resources in the county as well, which would include a diabetes self-management plan or self-management program through the Bureau of Aging. We also have diabetes self-management education through the Diabetes Center at the hospital as well. So as part of, in addition to these programs, as part of the initiatives, the diabetes is a priority in Maryland, and of course is a very high priority within our county as well. The state of Maryland does have a diabetes action plan, which you can access. There's a hyperlink in this slide. So once you receive access to these slides tomorrow, you'll be able to access that as well. The Local Health Improvement Coalition Redesign Grant does include additional diabetes initiatives as well, which includes working with, actually to accomplish that, we are working with the Partnerships Nutrition Action Team. So we are working with them to create a web page with the pre-diabetes and diabetes resources that are available in our county, which are just a few of the ones that we have are the ones that I just described. We're also working with the Nutrition Action Team to build a communications campaign to raise awareness of the resources and pre-diabetes risks, as it seems that a lot of people in the county and even doctors' offices may not even be aware of the resources that we have available. And a lot of people don't realize that they are actually at risk of pre-diabetes or even have pre-diabetes. One other thing that we're working on is to come up with some incentives for individuals that do the pre-diabetes screenings, in addition to participating in the classes as well. So we also the health department did also receive a new Care First grant to expand our ability to provide evidence-based lifestyle change programs in the community. Examples of that would be like the diabetes prevention program, some other weight programs, evidence-based weight programs as well. So as a part of that grant, we are actually hiring a community health outreach worker soon, hopefully within the next couple of months, who would be able to partner with some of the agencies in the county. So if anybody actually knows of somebody that would be interested in a job like that, we will be hiring for that soon. And then we're also looking forward to spreading more awareness of diabetes initiatives and programs and resources in the county as well.
All right, thanks, Lauren. So our next slide, I felt like it couldn't be a health meeting if we didn't talk a little bit about COVID, since I'm sure you're aware that those of us at the health department have been working on COVID nonstop for the last couple of years. And so we asked our new deputy health officer, Dr. Robert Wack, to just give you a quick overview. I realize this still says COVID poll, which I don't think we're doing, but to just give you a quick overview of where we are with COVID and the kind of the resources that we have to offer the community if any of you are interested in taking advantage.
Is that a handoff to me, Maggie?
Yes, it is.
Okay.
Yes.
So one of the roles, first of all, thanks everybody for joining this tonight. This is very important work that we always need to get as much community input as possible for developing what our priorities are. So quickly about COVID, we are entering a lull. It's not clear yet how long our little break is going to last, but I encourage everybody to get vaccinated and boosted so that you can enjoy the spring and hopefully the summer until something else happens. But I think for the next 3 to 6 months, we're going to get a break, and we should take as much advantage of that as possible. However, that doesn't mean that we should let down our guard, and the pillars of our COVID strategy are still in place and still remain true, and that is number one: vaccinate, vaccinate, vaccinate. If you're not vaccinated, please get vaccinated. If you've gotten the primary series but need a booster, please get your booster. And if at some point in the next couple months they say we need to get another booster, then get another booster. because the data is crystal clear that people who are vaccinated don't die as often as people who are unvaccinated. Depending on what data you look at, it's startling how much the vaccines will protect everybody from serious illness and death. So please get vaccinated. Second thing is masking. We are heading into a period of decreased transmission, so that soon you'll be hearing about mask mandates being lifted. But that doesn't necessarily mean that nobody should wear a mask or nobody has to wear a mask anytime, anywhere. If you are somebody that is at risk, because of your personal health situation, or you have somebody in your life that is vulnerable because they have an immune deficiency or some other medical condition, then it might make sense for you to continue to wear a mask, and that's okay. You shouldn't let all the craziness and disinformation out there make you feel bad about protecting yourself and the people around you by wearing a mask. There's nothing wrong with that. However, transmission is decreasing in our community fast enough that soon you won't see many masks out around in the community. But that doesn't necessarily mean that we're finished with masks. So, hold that thought. And then the last thing is, crowded situations are always the highest risk for transmission. So again, if you are at risk, or if there's somebody in your life that's at risk, just, think about that. It's not to say that you shouldn't go to a restaurant or you shouldn't go to a crowded situation, but those are the higher risk transmission situations. So it's just, and that's not going to change. We've done a really good job at the health department trying to get facts out there and sharing the truth about what's going on and what works and what doesn't work. And we will continue to do that. Unfortunately, there's a lot of really bad information out in our community. And that bad information isn't just, an annoyance or embarrassing. It actually kills people, and people in our community are dead because they listened to the bad advice of people spreading disinformation. So please do your best to get the right information and don't spread bad information. And it's hard because because of social media, we swim in a sea of bad information, but the good stuff is out there, and we've tried to do our best to be a reliable source for you. So, if you have any questions, please feel free to reach out. We've been providing testing kits, masks, and we also have continued to put to stand up vaccination clinics. We'll continue to do that, probably not at the same pace that we've been doing. That's going to slow down a little bit, but we will always be there for the community to provide those resources. And we're also, a place for sharing information, sharing stories, and we want to continue to be your trusted resource for reliable, true COVID information. And then I guess we have that community health outreach worker position. Is this an ad? You want me to promote this, or you're on mute, Maggie?
How did I? Okay. The position that Lauren mentioned is actually going to also be part-time COVID. So I just wanted to let folks know that that same position has, if somebody's interested, would be working on both diabetes and some COVID outreach, because as Dr. Wax said, it's not completely over. We're hoping to have a long period where things can be a little bit more back to normal, but there will still be things to do and still be data to collect and things that we want to make sure we're prepared for whatever comes next. So there will be that position will be working in that area.
I like to call it the new normal. We're going to get back to the new normal, and exactly what that is remains to be seen. But we're definitely finished for now with the awful stuff that we dealt with for the past 6 weeks, and thank God that's over. So, like I said, enjoy the spring, and hopefully we're going to enjoy the summer.
That's for sure. Well, thank you very much, Dr. Wack. We're cruising through the slides. So Tasha, I know you already touched on this a little bit, but if you could kind of review and just give a little bit more detail. I just wanted to kind of say thank you all for sitting through some of that information. I hope it was helpful. I know some of it wasn't all necessarily new to all of you, but hopefully it was helpful. And now we really want to talk about ways to get involved. And it looks like we will have a little time for discussion after this. So if folks are thinking of questions they want to ask, or things they want to talk about, please feel free to start putting those in the chat, or we can start raising hands, things like that after this. But just wanted to give Tasha a chance to talk about some of the opportunities for folks to get involved moving forward.
Right. So we hear all this stuff and we ask ourselves, what can we do? How can we help? And these are some ways that you can get involved and help with these initiatives. We have the Advancing Health and Wellness Leadership Team. Under all of the leadership teams, we have what's called our action teams. And so they're the ones, again, like I said, who get the work and really push forward with getting the initiatives done. And then we have, so Advancing Health and Wellness Leadership Team. And this leadership team really inspires and empowers Carroll County residents to adopt healthier behaviors. And so leadership teams, the nutrition action team, and we have a physical activity action team that lead that leadership team. Then we have our healthy aging leadership team, and that focuses on adults 65 and older. It's shown in our county we have a rising population of seniors, and by 2035, 1/3 of our county is going to be over the age of 65. So we really work to focus on educating the community to be healthier and to live longer life. So then we have the CARE, which is our Carroll Anti-Stigma Resilience efforts. That falls under the Access and LHIC leadership team. And that is our, it's kind of our efforts to address stigma in the county. One of the biggest barriers is to receiving treatment is stigma. So we want to address that and change that conversation for the county. Of course, the Access to Care leadership team, that's where this falls under. It's what this is, and Dot and Sue currently lead that team. And then Amy and I lead the Class and Health Equity Work Group. And again, that meets monthly. And then we have other, like if you want to do there's other opportunities to be able to work. Maybe we feel that we can do evening meetings or things like that. That's where that would fall under that. So, and you can, if you want to join any of those, Maggie just put in the chat that you could just reach out to Maggie and let Maggie know which you'd like to join, and she can get it to the appropriate, get it back to me or to Amy, to those who need it. So thank you.
Great. Well, thank you all. That was very efficient. That's nice to know that some people speak as quickly as I do. So we got through a lot of information. I had hoped to do this as an actual poll, but we couldn't figure out quite how to do that. So these are a couple of questions I was interested in asking the group. Of all of the things that Tasha just mentioned, I didn't add to the last slide, but the Tobacco Coalition is also a group that meets regularly. And as Tasha mentioned, a lot of these groups meet during the day. They're daytime meetings that we hold. And so, if there are other members here tonight who are interested in getting involved but aren't able to meet during the day, that's something we'd love to hear and talk about. So if folks would like to, as I said, you can certainly reach out to me or to Tasha to get more information and more details about when those groups meet. But if just for fun, if you wanted to put in the chat anything that you're interested in joining, it would be fun to kind of see how the interest is. And in lieu of a poll, just letting us know what you're interested in participating and getting more information on. And then I also just kind of wanted to gather some information about how people feel about virtual meetings. I think, as Dr. Wax said, hopefully the next few months will look a lot better and we'll be a little more comfortable getting together. But I also understand that, as he mentioned, some people need to take more precautions because of their own health or those around them. And so just interested to know of people who are interested in getting together and working on some of these issues, how comfortable you are getting together in person, or if you feel like you like virtual meetings. or if you want to, to try to combine and do some hybrid meetings. So just looking for some feedback on that informally in the chat would be great. I see several people are already chatting there, which is great. And then we have about half an hour, a little bit more than half an hour. So if anyone has questions for any of the presenters, if anybody has ideas that they want to bring up, now is the time. So Lauren and I will try to monitor the chat as best we can and kind of invite people to speak just to try to make sure things kind of go smoothly. I'm going to wait and see if anybody has any questions about any slides before taking that off. But in a few minutes, if we don't have any slide questions, I will stop sharing so we have a little more space.
Maggie, I think there was a question about the prioritization slides, the order
Yes.
of the.
Oh, thank you. Yeah.
If you could slip back, I think it was around slide 10, maybe 10, 11, something like that.
Thank you.
Sure.
You can all tell my buttons are a little sticky, so it takes like 2 hits to go backward.
I hear you clicking away.
I know. All right, is that good?
It's not quite. There it is. There it is. So there was a question, I
yeah.
believe there we go, in the chat that asked if this was the order they came in. And yes, this is the order that they were prioritized in. So mental health ranked number 1, diabetes, cancer, heart health, obesity. And just to elaborate on that a little bit, the way we prioritize those were by ability to impact and seriousness or significance of the problem. So we did have a rating scale of 1 through 6, and that is how we came up with the top 13, with mental health coming in clearly as the top priority. Diabetes, cancer, heart health, they're all similar, that they can be addressed with some of the same activities. So that's what you'll see in the advancing health group. And then we threw in obesity. We usually only do 4 because that's what we can manage in a 3-year period. But we threw in obesity because, again, it is a great impact to both to heart health, cancer, diabetes, and even to mental health. We see some of the care issues that come when we have mental health concerns going on. We sometimes see some of our other problems, health issues being neglected, I'll say. So any other questions about that? Can I elaborate any further on that for anyone?
I asked that question about the priority. The graphs that came a couple of slides later, are those in this same priority that the one we're seeing on the screen now?
Nope, I just put them up there. I mean, they're the same. You see that they're the same. We're sitting in the same order, basically. Although I combined a couple of them just because we were running out of space. Some of the drug use we put together, but other than that, they were. And then the ones at the bottom were things that people added. So yeah, so they were in the same order, but obviously, selected a little bit. Well, actually not completely because suicide got up there. So I'm not quite sure how that happened. For the most part, you see diabetes, cancer, heart disease, stroke, and obesity underneath mental health. So those were pretty much in the same order, but somehow I think we put suicide up with mental health because it was, kind of related. So roughly in the same order, but not exactly in the same order. And then I added a few, additional ones at the bottom that were more social determinants of health. So sorry about that, Kim. Thanks for clarifying. All right, does anybody else have any other questions, comments, things they want to share? Yeah, well, for those of you who know me, I like to fill space when there's space in meetings. I have a hard time just listening to silence, but I did want to say it is challenging sometimes to have virtual meetings and to have a discussion in a virtual meeting. And I appreciate the fact that so many folks were willing to sign in and listen. I know that this isn't always an easy way to discuss things, and we're very open to getting together other formats in the future to make sure that we're getting more feedback from you all. All right, let's see.
Maggie?
Yes.
One of the things that I've noticed because of COVID, we're going to be seeing a rush of people who have not been getting mental health care or be going to get services and so forth. And I don't know what we're doing currently to, when we finally get through this and people start showing up and they have late stage cancers and they have, they weren't treated for mental health. I think we got some real problems coming up, but unfortunately, I don't even have an answer. I know populations that I normally see have fallen off drastically, primarily because of being afraid to go outside the house. And yet, time they get to me, it's crisis time. You know, they waited so long because of the COVID that by the time I get to them, you know, we're in an emergency status all the time. So I don't know how we're going to address that with our Carroll County community, but we've got to figure something out to get people back into the groove of taking care of themselves and going to doctors and getting the care and so forth.
You're correct, and I'll wear my hospital hat at this point. But I think that did compound the issues, what we were seeing when COVID hit over the last three months or so with the hospital numbers. We were seeing COVID patients. That's clearly easy to say, very sick COVID patients, but we were also seeing very critically ill patients as well that really hurt our numbers. So I completely agree with what you're saying. As you know, we do Healthy Carroll Vital Signs and we update them every 6 months. So on that, we're actually tracking the ER visits and doctor visits, and we've seen already the increase. It's kind of, we're wondering how much of it's a rebound, because so many people say for mammography, they didn't receive care. It was actually closed for some time in 2020. So they didn't receive those tests. We're actually seeing a huge number now, and we're wondering where the rebound's going to say. So I think we're going to be seeing some fluctuation in all those numbers probably for the next 2 years. I would say we'll be adjusting to that.
I wanted to ask about the one thing that came up during the slides, talking about lack of knowledge. I have found in my years of being a nurse that that's a huge reason for these health inequities. So I wanted to know your thoughts on that, because when I go in to see a patient in their home and they're diabetic and they don't even have a glucometer to monitor their blood sugars, but yet they're seeing a physician, it kind of blows me away that they don't even know how to manage their disease process.
Okay, so it was quiet, so I'll jump in here. Judith, nice to meet you. I would like to say for that, when we asked the question lack of knowledge, it was something that actually I was curious about, because when I read it, it was actually my answer. Because for me, the lack of knowledge meant that there are services out there that people don't know about. So that was the way I was reading that lack of knowledge. So I'd be really interested, because it seems that your interpretation of that was a little bit different. So I think that's a good point, that we need to clarify what that lack of knowledge is. Is it on the patient's part of what they need, or is it lack of knowledge of the services that are out there? So I think that's a good point as well.
Thanks.
Yeah, and definitely, Dot, one of the things that, that the Nutrition Action Team is looking to do, and that Lauren and I are working on, is to make sure that not only are we working, to make sure that individuals know about the resources, but that providers do as well, and know how to refer to them, because as you met, that's an important part of the process as well. And a lot of folks, I think, will, be more likely to pursue something if they feel like their doctor has referred them there. And so that's definitely part of our work. Yes, and lack of follow through is definitely an issue as well, which is one of the reasons we're working on incentives, healthy incentives. The Nutrition Action Team has some great ideas for some healthy incentives that we'll be putting into place in the next couple of months.
And do we have a glucometer program for Carroll County?
Not that I'm aware of. We do have a blood pressure cuff program so we're able to do blood pressure cuffs sometimes for self-managed blood pressure, but we don't have a glucometer program. That's an interesting idea.
Yeah, because so many companies actually give them away for free, so it wouldn't cost the county anything. It would just be getting them out to people.
Right. Yeah. Thank you.
Maggie, it's Amy. If I can go back to something that Lou said for one moment, because he talked about not only kind of the somatic health, but also the mental health of the community, and the needs that we may see coming forward out of this pandemic. And I think, we're trying to be as prepared as we can for that. Carroll County has added about 5 new behavioral health practices over the last few months for the public behavioral health system. So what we work with through the local behavioral health authority, we make sure that we answer those questions for all citizens. So of course, if people are having trouble navigating the system or getting behavioral health services, we want to know about it. And we want to make sure that we have service coordinators that can help navigate that. And Lou, of course, you know how to reach us. So we know that you'll call on behalf and advocate for any of your clients that come through your door, as we also refer, back in your direction. So we just want to make sure that people know that the local behavioral health authority is there. And we have staff who answer those questions and help people navigate through. It can be really tough, particularly when you're in a behavioral health crisis. So we want to make sure people are aware of the services. The second thing I'll say is that for people who may not be aware, there is a mobile crisis team in the county, and they operate 7 days a week, 16 hours a day from 9 a.m. to 12 a.m. And I can put that number in the chat. And that's really for any kind of mental health or substance use or domestic violence or any kind of behavioral health crisis, which the individual defines as a crisis. So they can call that number directly and potentially, they'll triage it, but they could get a therapist and a peer support specialist to their home. So we want to make sure that people know there are lots of options, and they shouldn't get discouraged if they make a couple of calls and don't get exactly what they need right away.
And if I can add, I was just going to mention the behavioral health directory that we have, that people have access to, and you can get that on our website. But we're actually working on updating that. It has been since 2019. So we know that some practices have opened, but we are actually going to be creating a database. It's going to be a searchable database on our website that you'll be able to go in and search, whether it's mental health, substance use, resources in the county. And it'll be a searchable database that will have all of your information for the providers, including hours, insurance, and things like that people will have access to be able to search directly on our website.
Tasha, thank you. One of the things that I would love to see is a clearinghouse of some sort for state, federal programs. My clients are seeing some amazing problems where they can't even get somebody on the phone because the agency is working from at home, or whether it's Social Security, social services. There's this incredible backlog. And people are getting so frustrated because they can't even get the basic information they need. And that's one of the things I put down as far as a knowledge base. We really do need a clearinghouse where when a person gets frustrated, I had one the other day, she had called, probably 20 groups and could not get a resolution to her problem. And I basically, said to her, look, I don't run the federal government. I have my limitations too, but we really need to figure out a way to, because I don't know if you guys have noticed, our clients are getting a tad angry because every time they get to a state or federal agency, they are just getting this wall and not getting a real human. It is amazing, amazing time.
Lou, again, one of the things I can say with Social Security, and I agree, it's been a very frustrating time and lots of our clients need those Social Security benefits. What we often will do when we have clients who need a response is we'll do a 3-way call with them, and we'll get on the phone with them. And, we can't do it for every community member because we probably spend all day, every day doing that. But we also encourage, I don't know if this always works, but I encourage people to call Social Security at about 3:30 in the afternoon. And that's when people pick up the phone and they get a person. and they can get some of their business conducted. So I don't know if that'll be helpful in the people who are calling you, but we've had success in that way, at least with that one agency.
Yeah, and I appreciate that. I mean, one of the things that, it's you never know what to tell your client anymore. Are they going to be open on Tuesday? Who knows? They may, and you get frustrated because there's no clear communication between all the agencies that says, hey, here's our new schedule under COVID. We're opening up more. We're going to be open. As I say, I don't know the thing, but I do know that our clientele is getting very angry. I mean, they're just getting so worn out, and it's frustrating for them.
So thanks everybody for that discussion and for a lot of the resources. I think several people put resources in the chat. So if you can see that, take a look and make sure you're looking for the links and phone numbers. The partnerships website has some great resources. As Tasha mentioned, the behavioral health resource book, and also a lot of the action and leadership team information and data. So I highly encourage you to look at that if you haven't before. I had a question actually for folks who are from or connected to any churches or community groups. Are there things that that the Local Health Improvement Coalition, the Access Team, or the Health Department or the partnership could do to work with you to bring, just to do more outreach and to bring some of this information and some of these resources to you and to your your congregations or your groups?
Maggie, one of the things that's happened is that the ministerium, due to some ministerial transitions, a fair number of them in town, the ministerium is sort of in a lull at this point. We're not really meeting on a regular basis. And that is a structural systemic issue as well. There's no clearinghouse. The ministerium used to function as that, but it's just not there right now.
Oh, thanks, Marty. Anybody else who's on have suggestions for other sorts of outreach that we should be doing? It's kind of exciting to even think about, since it's been a while since we've been able to even contemplate the idea of doing outreach. But like I said, we're open to other suggestions for things that we might be able to start to plan. We've had a long period of time where the only thing we were really able to offer were COVID vaccination clinics over the summer. And I know we had some conversations about folks who might be interested in doing something like a, self-managed blood pressure or, a sort of diabetes education event, things like that. So just looking for any ideas like that or things that folks think that might be valuable.
Maggie, years ago, we had a listing of all internal phone numbers for all agencies.
Remember that?
And I would love to see that again, because if our clients can't get through, it's always nice that we had that one number where we could call somebody at the health department, or we could call somebody at social services and say, hey, we're at a critical stage. The person's going to become, out in the street or die. We need to find a solution right away. And you don't use it on a regular basis, but we really do need those crisis numbers for our agencies, like we did in the past, because that was just absolutely wonderful.
All right, putting in my notes, the secret list, the secret phone list.
Hello, Maggie.
For crises. So, hi.
Hi, this is Rodney from the NAACP. I think we have a
How are
health
you?
coordinator that's is trying to align with you all to have more communication between us and the health department. From what I was reading on your slides, that diversity piece, I see it's in writing in the policy, but we need to see more of that practice so that the information that needs to get out can be better outreach to those various communities that it needs to administer these programs to. And that lack of knowledge or information is one of the primary principles of why some of these, there's a lack of diversity within the organizations, because if we don't have the information and we don't know what's available, then it's hard for us to apply for the positions and be a part of the LHIC as you all are trying to adopt these programs. So I see the policies and all these things. We just need to see the practices of implementing some diversity and these programs being more beneficial to those that are need-based to help those in those communities. So, but that's a conversation it can be ongoing, and we're more than willing to have. So I appreciate the opportunity to listen to this presentation, and I didn't see my health coordinator on here, but I'm sure that she stays in communication with you as well.
Yeah, we're happy to have and take specific suggestions to increase, as I said, community engagement. And the idea is really the idea of this meeting was to really reach out to a more diverse group of people in our community, more representative, so that we could make sure that we were hearing from and communicating with our entire community. So I appreciate your comments, and definitely appreciate any further connections, ideas, ways that we can work together to increase and improve that, for sure.
Maggie, this is Leslie Wagner. I'd like to add that.
Hey, Leslie.
Hi. If anyone has any questions, that can be directed to the Bureau of Aging and Disabilities for older adults 60 or older, their family members, caregivers, and those with disabilities. You can call our main line and talk with our staff in our MAP office, which is Maryland Access Point, also known as Information and Assistance. And they have a lot of resources in the community, statewide, federal grants, programs that can help individuals. So it's always worth a phone call to them if anyone has questions, and they can help you work through your options to help your family member. So, and that phone number is 410-386-3800.
Thanks, Leslie. If you're if you're able to drop that in the chat too, that would be great, just so folks can cut and paste, or Lauren's keeping track. That's helpful. Thanks. I think as you spoke, I thought, one of the challenges I think is to make sure that people who need to take that first step know how to take that first step. And we're all here because you all got a message somehow through one of our networks, which is great. But how do we expand and how do we reach out even farther so that we can encourage people to take that first step to connect with one of our agencies or services? Then hopefully, with the no wrong door policy, they'll get where they need to be and get the services that they need. So that's why we need your help to help us connect better with the entire community, to help spread the word, to help get that information out, through trusted sources, through all of you. So that was one of the reasons I really wanted to have this meeting tonight, and to really have an evening meeting where we could have a discussion with additional folks from other groups. And so I will be following up with the slides and with a few other links and resources in the coming days, and also the recording of this meeting for those who weren't able to attend, but also for those of you who are here tonight to share. And really encourage you, if we don't come up with next steps tonight, that doesn't mean that there can't be next steps that include some or all of us. So we want to invite you to join any of the groups that we have already. But as I said, they for the most part meet during the day. And so if that isn't an option for you or someone else you think would be interested, we're open to other ways of communicating and meeting and involving other groups. And so, as you think of things and as we do follow up, please do stay in touch and please share those ideas.
Maggie, I wanted to follow up on Lou's comments and a couple other people's comments about the mental health issues in the community. And I just wanted to make sure that everybody had it on their radar screen that not only do we have the mobile crisis team, but there's a lot of legislative efforts right now moving forward to expand crisis services throughout the state. And that's coming in a variety of forms, whether it's regional crisis support centers or it's expansion of the mobile crisis teams we already have, or it's the Greater Baltimore Integrated Regional Crisis grant that Carroll County is a part of. I just wanted everybody, if you want to know more about those things, the Bureau of Prevention, Wellness, and Recovery is the linkage to that. If you want to get involved, I know right now they're doing work groups on the call center because we're going to be part of a regional call center. We're going to be part of same day access, where if a mobile crisis team comes out, they're going to be able to plop you into a mental health appointment slot within a day or two of that visit. They'll do the follow-up. So these are all really important things that are going on. And if you want to be a part of that, and all of these will be available throughout the lifespan. So it's not, and mobile crisis right now is available throughout the lifespan. So if you have a 5-year-old that's having behavioral issues and you need to call the mobile crisis team, they will help you. And it wasn't until we had a mobile crisis team that we were able to understand that law enforcement was alone dealing with some of these issues, but law enforcement going out to a house who's got a child with a behavioral health outburst isn't following up with the behavioral health provider that child's sitting on a waiting list for and bumping them to the top. So once we had mobile crisis, we were able to implement measures that helped the kids that really needed the help get bumped to the top, so that we weren't involving law enforcement or other resources, but we were getting them to where they need to be. And we have a long road to go, but I wanted everybody to know that those new initiatives are out there, and there's a huge focus on that right now, and trying to get the behavioral health issues that are going to the EDs out of the EDs. They're there for very time sensitive mitigating of emergencies, not to do detailed discharge planning and getting them to their next steps. That's what, the community-based programs are for, and that's what we should be using. So I just kind of wanted to give that plug so that if people have that interest, that they understand that that's going on.
Maggie, I know that there are all sorts of efforts to reach out all over the community, and I am so appreciative of that through class, through the needs assessment, really across the board. I'm curious though, I look at there are 34 of us here this evening. Does anyone feel like they have a meaningful connection with the Latinx community?
So I did invite some folks, and we have had some luck with our needs assessment focus groups. As Doc can tell you, we have been able to engage some folks, and we did actually really have a lot of luck engaging some folks in that community for some of our vaccination efforts through St. John's. So that was very successful. I did reach out for this meeting, but had some conflicts and some issues finding somebody here, and it is, we couldn't quite figure out how to translate a meeting if needed, but it is definitely one of the areas of focus, and something that we would like to do more of, just trying to figure out how best to engage that community on an ongoing basis. So if folks have suggestions for that or other connections you'd like us to try to make, that would be great. The other thing I wanted to mention was diabetes, since we had mentioned that was a real focus area, and I think might provide some opportunities for more community outreach in the coming couple of months. as Lauren kind of went over some of the things that we're working on with the Nutrition Action Team, with Tasha and the partnership, you know, these incentives and this website, which will hopefully be up in a few weeks, the webpage with resources, and then we'll be doing an outreach campaign, as Lauren mentioned, to really raise awareness of pre-diabetes and diabetes. And that's something, raising awareness, something that everybody can help with. You know, you'll have to let me know if you don't want to be on our mailing list, but I will add everybody here to our some of our mailing lists, our Access and Local Health Team mailing list, so that you'll receive information about those initiatives. In fact, I was just thinking as I was talking that it'd be nice to have some sort of newsletter that kind of, you know, kind of fills folks in on all the things that are going on. So there, when there are opportunities for participation or for assistance and outreach or for suggestions, things like that. So people who can't maybe regularly come to meetings, but want to still be able to participate and have feedback. But anyway, informally, we'll certainly send out emails with some of those resources. And so please do be on the lookout for some of the diabetes information. And if there are opportunities you see for further outreach in the community that you can help with, please let us know. So I think that will really be the focus of the next few months here. And then hopefully, as we hire that community health worker, we'll be able to kind of continue to further those, the referral process, and really get more people engaged in some of those classes that we have, and expanding what we have available. So if anybody else has any thoughts, things you want to share about diabetes, or thoughts about that as we move that forward, any suggestions? Okay, well, I think we're nearing the end of our time. I think we managed to have a relatively good discussion with a large number of people, so thank you all for that. Is there anything else that anybody wants to talk about, or anybody that we missed a question or comment in the chat that you'd like to bring up? So can't see everybody at once, so. If not, are there any of the presenters who have a final word they want to say, or anything they want to mention? Have we all talked enough?
I would just say, yeah, thank you for bringing us together. I'm sorry, Dot. Thank you for bringing all this together.
I was going to say the same thing. Yes, thank you. And just again, thank you to CMC for being here and organizing this as well.
Yes, thank you. Definitely want to help thank the Community Media Center. They all got on early. They all made sure that we were all right side up and could be heard, and that I could figure out my slides and all that. So that was essential assistance there. So one thing I definitely didn't hear, I may have missed this, but I didn't see a lot of responses on folks, thanks Richard, about next meetings or virtual meetings. So obviously we've given you lots of opportunity to get involved in other meetings, and we will send out more details about those. But if there are folks, if we do decide that, you know, as a group that we want to have another kind of check-in meeting or community health planning meeting, does anybody want to share any preferences they have for virtual meetings versus hybrid or in-person meetings? This would be a great time to do it. Otherwise, I'll probably be asking again. So feel free to put that in the chat if you don't feel like saying that, and then I will let you go. Thanks, Judy. One thing that I know, the library, if you haven't seen the new makerspace at the library, it's fantastic, the Westminster Library. And it's really, it's got a great space, and they have some opportunities for hybrid meetings as well there. So that being another place we can get to. All right, we've got lots of votes all over the place. All right, folks, well, maybe we'll be able to do a little bit of each. So thank you all for participating. Thanks for taking time out of your evening to be here. Thanks again to the Community Media Center. Thanks for the 17 people that I made present tonight in random order. So thanks for sticking with your slides and doing all that. I appreciate all of that. I will be following up, as I said, in the next couple of days. So please look for an email from me. Please feel free to reach out anytime before that, after that, with additional ideas, comments, questions, suggestions, and we will stay in touch. So thank you again for your interest, and have a great evening.
Thank you. Have a good evening.
Bye, everyone.
Night, night, everybody.